on. So we have these three main aims for the session today. We're going to think about the key barriers that face people from inclusion health populations when they're trying to access healthcare. We're going to think about what that does to people, what the impacts of those barriers are in terms of their health outcomes. And then finally, we're going to think how empathy or empathy-driven approaches can help overcome some of those barriers. And we're going to hear from Ray how he uses that in his practice now as well. So I'll start by giving a definition of inclusion health for those of you who are not familiar with it. It's an umbrella term. It describes people who are socially excluded. And one of the issues that most socially excluded people face is they've got multiple interacting risk factors that cause them to have poor health. So stigma, discrimination, poverty, violence, and complex trauma are all overrepresented in inclusion populations. And the people in inclusion healthcare groups include quite a wide variety of groups, but these are the ones that you see most commonly when we talk about inclusion healthcare. People experiencing homelessness, gypsies and travellers, sex workers, vulnerable migrants, people in contact with the justice system, people with substance use problems, and victims of modern slavery. And what's really important to realise is that there's a lot of intersectionality between these groups. People don't tend to stay within just one of those groups. So you may well find that someone who is experiencing homelessness has also got a problem with substance use, maybe is a sex worker, and maybe was a vulnerable migrant as well. And people move in and out of those groups as well. So for instance, someone may be experiencing homelessness now, but in 10 years they've moved on from that and become housed. So it's not a label that necessarily follows someone around for the whole of their life, and that intersectionality is an important thing to consider. For the purposes of today's talk, we are going to be focusing on people experiencing homelessness, but a lot of the stuff we talk about today applies across other groups as well. So why is it important? Why should we be worried about inclusion healthcare? If we look at people experiencing homelessness, they have significantly worse physical and mental health than the general population, with over 60% of people experiencing homelessness describing a long-term physical condition or disability. And that's compared to 22% of the general population, so 3 times the rate almost. 82% have a mental health diagnosis, 72% of that is depression. If you look at the national rate of depression, it's around about 16% of the general population. And there are higher rates of post-traumatic stress disorder, psychosis, and personality disorder than in the general population. Having said all that, anxiety and depression are the most common mental health diagnoses that you see in people experiencing homelessness. 45% of the group are actually self-medicating, so using drugs and alcohol to cope with those mental health diagnoses and perhaps the situation that they're facing in their lives. And in this study in the London hostel, they went out and they did a frailty score on people in the hostel in the way that you might do on a geriatric ward. And they found that the frailty of the people living in the hostel was comparable to that of 89-year-olds in the general population. The average age of the population in the hostel was 56. So they measured grip strength, cognitive tests, mobility, etc. And this compared to an 89-year-old. So you can see the burden of being homeless is pretty bad on your physical and mental health. And this is a graph that always shocks me, no matter how many times I show it. This shows the mortality rates as you become more deprived. So the people towards the right-hand side of the graph are in the most deprived communities. And as you'd expect, as people slip down into deprivation, their health outcomes are worse, their mortality ratios are worse. If you include homeless people or people who are sex workers or in prison or with drug use problems, you get this. So there's a huge cliff edge of inequality. The mortality rates are much, much higher in those groups than they are in even the most deprived people who don't have those issues. And the average age of death for a person experiencing homelessness in the UK, 47 for a man, 43 for a woman. Pretty shocking statistics in a wealthy country like the one that we live in. So I'm going to go to Ray now. So Ray, if you could tell us, what was your experience of trying to access healthcare when you were when you were experiencing homelessness yourself?
I think the main barrier was me. if I'm honest. I was wrapped up in a drug addiction, which was priority. I was going to say first thing in the morning, really, but it was priority 24 hours a day. Um, Once I'd got my drugs, then I may think about going, could be to the doctors, dentists, accessing mental health services. It could be anywhere like that. But by the time I've got my drugs, the drugs sort of numb my thinking, and I feel okay, not bothered that no more, until I've not got the drugs again, and then all the symptoms come up again, mental health, withdrawing, um, and then at that stage I'm too ill to even think about making a phone call, think about putting myself into services. There was one occasion where I was suicidal. I was more than suicidal, actually. I tried to commit suicide, and a family member sort of interrupted me, and we went to the local A&E straight away. And in the A&E, it was explained what I'd just done and where my head was, and that I'm addicted to drugs, and there was no mediation. Well, I was left waiting in an area that was making me worse. Um, Eventually, after some time, I literally run out of the hospital. That kind of got their attention, and the security come and looked for me. Um, Found me. At this stage, they put me in a sort of secure room, a safe room. Um, I suppose looking back now, all I really needed was an interaction a little bit earlier, just to say, look, we're going to help you, or signpost, or anything, any sort of interaction, rather than just leave me waiting in an area where I was felt really vulnerable. And when I was put into the secure room, when I did speak to anyone, as soon as my lifestyle come up, I felt certainly didn't feel any empathy. I felt dismissed, if that makes sense. I didn't feel there was care. I understand now, looking back on it, how busy A&E can get, and how under stress everyone is. But at the time, I was wrapped up in my own emotions, and could only see what was in front of me, and that was someone who wasn't really caring, who I felt looked down upon because I was in addiction. I didn't feel I was getting the same care as someone who had severe mental health like I did, um, and not wanting to live. Um, I think I left. I think they give me some. I can't even remember what there was. Some sedatives, um, sedatives, and I left. Um, and I didn't really get much support, much signposting. There was no. I didn't get any. I didn't gain any hope from that interaction. And sometimes when you got no hope, that's all you expect, because it just it proves my thinking right, that I am hopeless. And so it wasn't long after that. I think it wasn't long after that I was back out using drugs to escape my reality again. I'm not blaming anyone in this scenario, um, because there has been other episodes where I've been really cared for. So, but you tend to remember the ones that hurt. Yeah.
Thank you, Ray, and thank you for your honesty and for sharing that. And and it's never easy to talk about these things. I'm interested that you say that there were times where you did find some empathy that was different. You're able to just give us just a short example of when someone was empathic and the impact it had on you.
Mm. I'm sure there's been many people over the years who've shown me great care and empathy. If I'm honest, I struggle to remember certain times because I wasn't in anyone's care for that long. I was always on the run. But two incidents stand out to me. And I remember when I first started injecting, um, I was getting someone else to inject for me. I wanted to die at this stage. I didn't really care. Um, and then I started to inject myself. And I remember the first time I sort of come clean, if you like, to the local drug service, and their doctor, in-house doctor, really made a difference. I'll never forget her. She sat me down. She had time for me. I could tell in her eyes that she cared. She was explaining to me the dangers, the real dangers, because I'm totally out of it most of the time. I don't stop to recognise the real danger, what I'm doing. And it's like Russian roulette. You don't know what you're injecting. And she really sat me down and spoke to me. She asked me directly, "Am I? What do I intend to do? Do I intend to stop?" And I was honest at that stage. I felt I could talk to her, and I wasn't ready to stop. I was going to carry on injecting, probably when I left there. And then she went on with the harm reduction, which I listened to. I can remember now. She was telling me alternative sites to inject, the reason why we should do that, what it will prevent, and she went really into it. And even though it's sad, I wasn't ready to really take on that advice, because I went on to ruin many veins by not following that advice. But it was the care that stuck in my heart. They say what comes from the heart goes to the heart, and that's what I felt in that interaction. It was really important, sincerity. Despite the fact that she was actually powerless over stopping me from taking drugs.
Yeah.
The care was still there, and that really made a difference.
Thank you. Great example, Ray. Thank you for that. We'll come back to you a bit later on, and just a reminder to everyone, if you've got any questions or anything or comments, please put them in the chat. Any questions for Ray, for instance, and we can ask him when we next get Ray speaking. So thanks, Ray, again. Thanks for your honesty. It's great to have you on board. Really is. So I'm going to move on a little bit more. So thinking about the barriers to accessing healthcare, and actually some of these Ray's actually just told us, so he's gone over some of those barriers himself. This is Austin O'Carroll. Austin O'Carroll, if you don't know him, he set up the Dublin training scheme, which basically trains GPs to work in inclusion healthcare in that area. Is an incredibly impressive person, and he said this about the health service. It's designed for middle class people, those with routines, who keep appointments and assert themselves politely and acceptably, value their health and have hope for the future. And it's really not designed for homeless people. And he's done quite a lot of research looking into the barriers that keep homeless people out of healthcare. And these are the main barriers that he came up with. So physical barriers, so basically distance to services. If you haven't got transport, or it's very difficult for you to get to healthcare, if you haven't got a car or a friend or a neighbour who can give you a lift there, can't afford a taxi, can't afford a bus, then just getting to the services can be really difficult. Administrative differences like registering for services, GP services even now still ask for proof of address when people go to register at a GP service, even though it's not required. And if you're a homeless person, clearly you don't have proof of address, so that is a barrier straight away. And people experiencing homelessness are 40 times less likely to be registered with a GP than people in the general population. So they're really missing out on what is, the most important access to healthcare in the NHS. Queues can be difficult if you get to the A&E or the GP surgeon. There's a big queue going out of the building. You've got ADHD or you're withdrawing from substances. Waiting in a queue is a really challenging thing to expect someone to do. Sometimes rules of service can be a barrier, particularly if they're quite authoritative. So you get removed from the list with maybe swearing in reception, or if you order your drugs late, your medication late, you can't have it because it's got to be done within a certain time. When people's lives are fairly chaotic and disorganized, doing those things is really challenging. And then sadly, attitudinal differences, stigma and discrimination from healthcare professionals to people in these situations, not treating them as well as they would treat other people because they see them as being a waste of time or a difficult person. And Austin identified these conversations of exclusion, which are also important. We'll all recognise these if we work in healthcare. We will have all had these conversations with patients. So the benzos conversation, it doesn't have to be benzos, it could be opiates or any sort of medication that is open to abuse. And that's often a quite stressful conversation for the healthcare professional. Everyone tells us we shouldn't be prescribing benzodiazepines. And if you do, you're a bad doctor. And then you've got this person who comes to see you who wants some benzodiazepines. And so that conversation can escalate quite rapidly, people getting angry, people getting defensive. And it is a case of trying to sort of think about reframing that conversation in a way that doesn't put a blame on the person there. And maybe if you're not able to prescribe, give the reasons why. The NHS doesn't like me to prescribe this, therefore I'm not able to prescribe, but I can help you in another way. I'm not going to say no to everything. The distrustful conversation. So people often are a bit suspicious of homeless people. They expect that when they come and say they've lost their medication, for instance, instantly assume that that's a lie, and actually quite often is, if I'm honest. And that's because telling a lie can be an essential to get your needs addressed if you're living in the street. And I think the way to deal with that is to firstly not take it personally. So if you find out that someone has been dishonest with you as a patient, don't take it personally. It wasn't personal. They're just trying to survive, and in some ways almost expect it. So you sort of think, well, yes, okay, well they may have been dishonest around that. That's okay. I'm not going to hold it against them, but maybe we'll have a conversation about how honesty is the best way to receive help as well as to access it. The blaming conversation, we already heard a little bit of that from Ray. People sort of looking down the nose at people. Well, if you take drugs, what do you expect? Or if you drink, what do you expect? And then the assertive conversation, this is a little bit the other way around. I mentioned that what Austin said about middle class people knowing that the way to get what you want is to be polite and persistent. Probably a lot of people who are living on the street, that's not a skill that's common to them, and often being aggressive or maybe shouting is how they survive on the street, how they intervene, and adapting that into healthcare doesn't work as well. So people get challenged for that, security gets called, all those things, when maybe that's not the most helpful for the person involved. Having said that, and Ray addressed this as well, a lot of the barriers are internal. There's a long list of internal barriers that can come out. I'll just go through a few of them. Fatalism. If you think you're not going to live very long, what's the point in taking care of your health? That is a thought that people, there's lots of publicity. I've already given you some statistics about how people die young who are experiencing homelessness. And most people who are experiencing homelessness will know people who've died young and expect that that's going to happen to them. So why bother taking care of your health? Self-blame. Lots of people who are addicted to alcohol and drug use actually blame themselves for it and actually themselves think that they don't deserve treatment as a result of that. Competing priorities. If you've found somewhere a good shelter for the night and then you've got to leave it to come for a GP appointment or a hospital appointment, you might not be willing to do that in case you then lose that position. If you've got a really good begging location where you're making a decent income and then you have to go to the surgery and when you come back someone else taken that over, those sort of priorities are going to stop you from maybe going to an appointment that's been booked. And as Ray said, if you're addicted to drugs or alcohol, that's going to be the number one priority for that day. Communication difficulties are much more overrepresented in this group. There's a lot of mental illness, there's autism is higher represented, brain injuries, prison and care histories are there. All of those lead to communication difficulties. And in this paper here, we talk about some of the solutions for that. Being aware of it is probably the first thing to think about. People may have communication difficulties, which you may need to adapt your normal communication style when talking to patients from this group. And all these factors come together to create missingness. And this in itself is a problem. people who miss a lot of appointments, and we're talking about people missing 2 or more appointments a year over a 3-year period, it's not a huge amount of appointments, have significantly higher all-cause mortality rates than those who don't. And if you couple that with a mental health diagnosis, they are 8 times more likely to die prematurely. So this is a research that just looked at people who'd missed appointments, not for the reason why they missed appointments, but just people who had missed appointments. And people who miss appointments are much more likely to have suffered an adverse childhood experience, have long-term conditions, socio-economical deprivation as well. So these are people who are really high risk. And often as a healthcare practitioner, and I've been guilty of it myself in the past, as a GP, if a person doesn't turn up, sometimes you think, oh, I've got a 10-minute break that I didn't know was coming. And actually, we should perhaps be actually trying to find the people who don't get to their appointments. So Ray, back to you. Does any of that resonate with you, actually? Those sort of things we just talked about there. Anything you want to add to that?
I think you ticked all the boxes, really. It brought up some emotions for me, if I'm honest. Just seeing it there, you've nailed it, really. The internal struggles is all of them. What was up there, I related to them all. My personality or how I felt about myself was so battered that when I did get an opportunity to get support from mental health services, drug services, and eventually go to rehab, when I was just coming off of the drugs and going on to sort of opiate substitute medication and another antidepressants, all I was left with was like an empty shell. And all I remember just always saying, thank you, thank you, thank you. And sorry, sorry, sorry. I mean, you could have come up to me and poked me in the eye. And I would have said sorry to you. I just felt I didn't warrant anything by that stage. I didn't. So it's quite a sad place to be. And it takes a lot of time to recover from that. It takes a lot of support, a lot of encouragement, but it is possible. So when I'm out there today, and we're working alongside people who have got multiple disadvantages, I don't see hopelessness. I see potential, and I really do. I've seen it not just in myself, but in lots of other people I've worked with, and a lot of my colleagues as well. So it's yeah, it gives me a different outlook now, and I think that's as a healthcare professional. I think hope is the main thing we can bring to the table. That's the starting point for anyone, really. Not false hope, but just a glimpse. That's all you need, is a glimpse. And that opens the doors to possibilities. And when you get a patient thinking about possibilities, and then when one of them possibilities become a reality, like they cured of hepatitis C, for instance, a killer disease that they was potentially going to die from, and they've managed to cure it, then does that open the door to other thoughts, such as maybe I can get off drugs now, maybe I can not drink alcohol, maybe I can do a bit of volunteering, it opens up a lot of potentials. And so I think hope is the best thing we can bring to the table, really.
Thanks, Ray. Brilliant. Again, thank you. So let's move on here. Thanks for that. So we're going to think now about empathy and how can empathy help, and that's the next focus of the presentation. And I'm going to show you a definition of empathy that's recently been published by the Centre after a systematic review of all the thousands and thousands of different definitions of therapeutic empathy that there are out there. I'm just going to go through some of the points on this, just to explain what we mean by the various labels there. So exploring involves practitioners using sort of non-judgmental listening and curiosity to gather information. So that non-judgmental bit, we talked about stigma before, and curiosity, just trying to find out a little bit more about your patient's life. And I think sometimes when you're dealing with people experiencing homelessness, it's often a case of let's just get through this quickly because I'm a bit nervous about what might happen. And actually, that curiosity can really make a difference, not just for the patient, but for you as a practitioner as well. Understanding is the next step, and that's where we're using our clinical skills or our experience to sort of try and understand the patient's situation. We don't need to have experienced it ourselves. And obviously, for most of us, fortunately, we're never going to go through the situations that Ray has described for us this afternoon. But we do need to sort of understand it. We need to comprehend what that might be like. We have to have some sort of understanding of how it might feel to be in Ray's situation. And then we need to share that understanding. And that's where we just check with our patient that we're on the same page, that what we think matters to them is what matters to them, what's important to them, what's happened to them is what we think is actually correct. And that then produces some sort of feeling. Now, you don't need to feel the same as your patient. So if your patient is really stressed, it's no good that we then become really stressed as well, because you're not really helping in that scenario. But you do need to have some feeling. It could just be concern, it could be compassion, and it enables you then to move on to the next step, which is therapeutic action. At the end of the day, we're in this for healthcare. We need to do something useful with this information, and that's where we can take steps to help. Now, that could be some treatment, it could be a referral, or it could just be being there, being available, listening to the person, allow them to tell their story, or as Ray has said so well, just giving that message of hope, a positive message. There's something we can do. This is, there is some hope for you. We can help you in some way, and maintaining boundaries. That's really that you recognise as a distinction between your experiences and emotions and that of the patient as well. So although you might not feel the same as them if you went through the same experience, but you just know that this is another person you talk about. At the end of the day, it's not you you're talking about. Sorry, I'm on a webinar. So let's think about those external barriers and then think about how empathy might actually break down some of those barriers. So let's start with the physical barriers we talked about before. And I think this is the one way I look at this is to think about the caring environment particularly. And it's worth, if you go to a GP surgery or a hospital, to maybe go into the waiting area and have a look around and think, is this an empathic environment? What are posters like on the walls? Are they warning people that their behaviour will not be tolerated, with pictures of policemen carting them off? Or have they got lots of posters saying that you're going to die of cancer if you don't have a test, or if you don't have a vaccination, you're going to end up in hospital? Lots of frightening signs. If you're an anxious person who feels quite stressed when you're in a healthcare environment, does your healthcare environment make that stress reduced? The rules of service, could there be some flex in your normal rules of service to allow the difficulties that marginalised groups face? So could the appointments time be a bit more flexible? Could you allow a little bit longer for people with complex needs? Do you have a policy that if someone turns up late, they're excluded, or could you maybe allow that to be different for people who are experiencing homelessness or from marginalised groups? Think about the attitudes. Can you challenge stigma and unconscious bias? Should all staff receive training on about homelessness so they understand some of the challenges that homeless people face, so that they lose some of that stigma and they're a bit more compassionate when someone comes in that scenario? And then conversations of exclusion, are you using them? Can you take a different approach if someone comes and requests that medication that you don't want to prescribe? Is there a different way of approaching that without getting upset or without it becoming an argument? And if you take all these steps, that helps to reduce that missingness thing that we talked about, not just for people experiencing homelessness, but anyone who is currently not really taking advantage of their healthcare system. And then we think about the internal barriers that we mentioned as well. Actually, this is really where the exploration thing comes in. So if you can explore a person's internal barriers, then maybe you can do something about it. If we don't ask about fear, then we won't know about it, but it might explain some of the behaviours that you see that might be seen as unacceptable. Competing priorities, could we make allowances for that? If we understand someone's competing priorities, can we accommodate them in some way? And if we demonstrate empathy, if we demonstrate that we care, we can start to break down some of these self-blame, fatalism, the presumptions, all those things can start to be unwound. If we show that we care, if we get that message of hope that Ray spoke about, and that caring approach that the drug worker took with him that time. And then communication difficulties. If you've got an empathic approach requires good communication skills, and good communication skills requires you to be on the same page as the patient. And in a nutshell, if people have got communicating difficulties, the simplest thing to do is just really slow down, and then slow down a bit more than you would normally do. The slower the better. You can't really go slow enough when you're talking to people with communication difficulties. And I really like these 4 rules of general practice that David Haslam created. He was the head of the Royal College of GPs, the head of NICE, and the head of BMA. Shut up, listen, do something useful, and care. And I think if we all apply those 4 rules in our dealings with any patients, not just people from inclusion health groups, but maybe particularly people from inclusion health groups, we can make a difference. We can really help them break down some of those barriers to healthcare that we talked about. So Ray, I'm going to go back to you again, Ray, and want you to talk a little bit about your experience using empathy in your current work for the Hepatitis C Trust. So how do you now use empathy in your current work?
Listen is an important one. To listen, to understand. And the more I can understand about someone and their life, the more I can think of the best way to reach them and treat them. I'll give you an example. This man had severe agoraphobia. I was trying to trace him down. He's been a known positive for Hep C for about 6 years. He was homeless. He'd been housed. Spoke to his social worker, and his social worker said to me, I said, we need to treat him. We need to bring him to the hospital to have an assessment. And she said, you've got absolutely no chance of getting him anywhere. He's not done his own shopping. He doesn't go out of the house. And just basically shutting the whole conversation down. And I said, can we set a meeting up? I'd like to have a chat with him. This was during COVID. And I said to him, I said to the social worker, I said, I'm going to see if I'd like to meet him, see if he'll jump in my car and I can take him, patient escort there and back to the hospital. And she went, I wouldn't get him in the car. She went, I'll just warn you, he's not had a bath since he's been here, and he's been here 18 months, like that. And again, I just some people I find on the journey can show us how we don't want to be, rather than criticise the situation. I just learn from the situation, and then I follow best practice with other people I learn from. So I went round there. I remember knocking on the door. He comes to the door. He's a big, tall man, 6'6". He was about 60. He had a long beard down to his belly button. He had long hair down to his waist. And he had the mask on, and I could just see 2 big, obviously scared, paranoid eyes. And we went in the flat, and he had a chair in the flat. He had no telly. The floor was, I thought he had a dog, because the floor was just covered in hair. Anyway, he sat down. I sat down on the floor, and I proceeded to talk to him. I sussed out whether you can find out whether people want you to make eye contact or not, and he was okay with that, I presumed, and so I made plenty of eye contact. First thing I said to him was, I'm here only to help you and to do what's best for you. And then we had a brief discussion where I said to him, I said about coming to the hospital. He went, no. And I said to him, okay. I said, well, we don't have to go there today, and at the moment. So I tested him. I'd done a dry blood spot test on him. waited for the genotype to come back. In the meantime, I'd over the next couple of weeks, I've kept in contact with him, maintained contact to build up the relationship. The day come that we needed him to get to the hospital, I went round there again. I said to him, look, I said, there's my car outside. Can you come in the car with me? We'll drive to the car park. I phoned the nurse in front of him. The nurse agreed to come out to meet him in the car park. And he said, in the end, he said yes. He got in the car. I did my baby's windscreen blocker, the sunscreen. And I said, do you want that up or do you want that down? He had his hood up. It was a boiling hot day. And he went, put it down, 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 just so he could hide from the world. And anyway, I got him to the appointment. The nurse come out. He went in, got assessed. And when he come out, I said, so how was that for you? He said, I can't believe I didn't run. Can't believe I didn't run, Ray. And that sort of broke the ice. And I remember looking in the window on the drive back, and he's looking out and he's looking at the shops. And this is someone who's not been out for 2 years, So anyway, long story short, I maintained the relationship, dropped his medication off to him over the next few months. And then it come for the final test, what we call a sustained viral response, SVR. He needed a final test to say that he's cured. And you know what? I phoned him and I said, we're going to have one more test with Nurse David again. Is that okay if I come and pick you up? He didn't hesitate. He said yes. I went round there, I picked him up. He went and got the SVR. We found out he'd been cured of Hep C. On the way back, the Hep C Trust, a really, really wonderful organisation, charity. So we get extra funding to really go above and beyond for patients. So we get to buy them McDonald's and give them food vouchers and stuff like that. So on the way back, I said to him, do you want a McDonald's? And he went, really? Really? And I said, yeah, come on, let's get it. I said, should we go and sit in there or drive through? He went, no, drive through. And so we drove through the McDonald's. I got him an ice cream and a burger, and it's boiling hot. And I'm driving, and he said, Ray, he said, the ice cream's melting. He said, is that okay if I eat it now? I went, yeah, of course it is, like that. At that stage, I'm thinking this must be a lot for him. He's never been out, so he can't get McDonald's. Anyway, I'm driving, and all I can hear from the back seat is, and I'm looking in the mirror, and it's like that was him just expressing the cheers, Andy. That was him expressing that he'd never tasted ice cream for a long time, and that was kind of the joys that the bit of hope and I believe one-to-one care can give. I dropped him home. I followed up with his social worker later. She said that he started to take out his own rubbish now, which is improvement. It also showed the social worker that he can do things. He can go out. We just have to try a different approach. And that was it, really. So thanks, Andy. Sorry if I went a bit over, as usual.
Not at all, right. You didn't go over it. It's a great story. I love that story so much. Thank you, Ray. So we're coming to the end. Actually, we're a bit ahead of schedule. So I'm gonna turn this out to everyone in the audience, really, and you'll have to send your questions or your comments through the chat box, and we can read them out. How do we ensure that the next generation of healthcare professionals don't add to these barriers? What do we do that's going to stop Ray from having those bad experiences that he had in the past, or people like Ray in Ray's situation as he was then, and have more of those experiences like Ray just described, where people generally show that they care about their patients and actually ensure things are going on. So has anyone got examples of things you're doing already, perhaps, or things that you think we should be doing? If you want to pop those in the chat. I'll mention a couple of things whilst you're having time to think about that and get your fingers warmed up. There's in Leicester, we have something called Project Light, which is an organisation within where medical students or students from other healthcare courses in Leicester can volunteer to come to Project Light, and as part of that, we're given some training on homelessness, on how to speak to people from homeless backgrounds. How to do health checks, all those useful things. And then they go out to the local charities and they go there and they talk to people and they help the volunteers and they do health checks and sort of generally engage people to get them to think about their healthcare. So that's a great initiative and it's something we're very proud of in Leicester. And I know there's a couple of students on from that here today. The other one is obviously Austin's North Dublin GP training scheme. So this actively goes out recruiting people with an interest in inclusion healthcare and training them up to do it as a career. And that's been a brilliant success. You know, where I work, inclusion healthcare, we have registrars. We've got a great registrar at the moment. And some of those registrars go on to be doctors with us in the future and carry on working into inclusion healthcare all their careers. So that's you know, it's great. We need more people to be interested in that. So has anyone got any ideas, any suggestions? If you want to pop them in the chat, I'll give you a minute more to think about that. The other thing we've actually done, which has been really great, is actually sending people out with Ray when he goes out on his visits, going to find people and trying to get them to access the Hep C screening and have their treatments. And that's been a really brilliant experience for the students because not only do they get to see people in the community who need the most help, they get to spend all the time with Ray as well. How great is that? Okay, so we've got some points coming in here. So counselling skills so far has trained and transformed my clinical experience. It's interesting you mentioned counselling. We were doing a presentation yesterday for some educators, and someone mentioned that they found that doing a counselling course had actually made them much more aware of empathy and thinking about empathy. And empathy is something that we can teach. We know that you can teach empathy effectively, and if you train people how to be empathic, they end up being more empathic. So that's a great example. It's all about getting on with people and gaining trust. Yeah, I think that's true. It's sort of been normal with people, isn't it? It's not adapting a persona. It's just being a normal person and being on the level with people that you're talking to and having that normal conversation with someone instead of feeling you have to be in this sort of power balance. You know, you can get down to the level of the people you're talking with and just have a normal conversation. Don't be an idiot, as someone told me this morning. Could be doing more co-production of education with people who've lived the experience of social exclusion. That's a great point, Gemma. Thanks for sharing that. And the point above actually sharing those powerful stories. So involving people with lived experiences we've done today. And I know that I've given you some statistics, I've given you some bit of background on empathy, but I know that all of you will remember what Ray said today with his lived experience far longer than you remember everything I said. And that's why I've invited Ray to come today, because I know the impact of what he said is greater than what I can achieve. So yeah, co-production, but that's slightly different than getting people to sort of help us to design the education who've lived through it. That's a really great idea. I think we need to adapt that too. Remind students about human elements of interaction with patients rather than adopt patients. Yeah, that's absolutely a really great idea. I think that trying to do that balance of power that I mentioned, and I think coming back to you, Ray, on that actually that power balance that I just mentioned, that the as when you're coming off the street into to see a healthcare professional, what's your feeling about that sort of power balance in when you were back in that scenario?
There might not even be a power balance there, but I've already created one because I've got such low self-esteem. Yeah, I've already created one. There's already a difference because no one's like me. I think it's just me. I don't realise this affects thousands and thousands of people. So that's hard to overcome anyway, even if you are trying to equal the sort of can't get my words properly then. Yeah, even if you're trying your best to make it an equilibrium, it's you're up against it really. What I've found over the years we're working with the nurses at Leicester Royal Infirmary is that when they see us and how we talk to patients, as you just said, on a level, um, they see us talking like that to the patients, and then we're introducing them to the patients, and then we leave them with the patients, and then by the second appointment, they're speaking exactly to the patients like we speak to them. And that fear, if you like, there is a certain fear there because I remember one nurse said, when before you come to work with us, I wonder what it's going to be like working with criminals. So there's a natural fear there, and I get that, I understand that. Um, but what I'm saying is the by watching us operate, they realise they can speak to them like it as well. They're just normal people. Yeah, some people, not many I've come across, but some people can get aggressive and have an aggressive attitude. And then if I usually turn that approach around to hurt people, hurt people. So they must be hurting about something. So I try and lean into that. But yeah, it's just creating a relaxed atmosphere, and I've noticed a lot of it. I felt like it, if I'm honest with you. I met you and Jeremy. Um, I still feel like that. I don't feel like it anymore because you totally made me feel comfortable. But initially, I'm thinking, wow, you know, it's just that natural self-esteem that's kicked in from years and years of abusing myself. So yeah, you're up against it, is what I'm saying. But it's just the way you and Jeremy was a great example of creating an atmosphere where I just felt relaxed and at ease and as one.
Thanks, Ray. Fantastic insight. Yeah, and actually, I think someone here has put this point about giving students and trainees time speaking with patients with lived experience through cafes and things. I think generally that's a great thought. What you've got to, like Ray has just sort of address there really is I have some empathy for the person in that situation, that they might be quite nervous about speaking to students as well. And so it probably works a bit better in this scenario when, like you suggested there, that people are going out to the community, going out to the sort of charities like Project Light was going out with Ray on his visits. Ray, you're going to get loads of people coming to want to visit with you after this talk. And then, nice point here, it's important to incorporate empathy into medical school curriculum to help the student understand its importance in providing compassionate and effective healthcare. Thank you for that. That's a bit of marketing for the Stoneygate Centre right there. That's just what we're trying to do at the moment. And I think my own experience, I mean, I've only really been doing homeless healthcare for about 5 years now. And it's that calm, relaxed, make the person feel like they've got as much time as they need is the only way to do it in my experience. I had a patient in the other day who was probably the worst ADHD person I've ever seen. Like he literally was unable to sit still for less than about a second, and was very upset because he thought the room didn't smell very nice. And it'd been quite easy for me to get a bit raw about that. And instead I thought, well, let's just go and go in another room. And just by doing that simple thing, which took literally 30 seconds, he calmed down straight away, just because he felt like I'd listened to him and taken on board his concerns. And I think, yeah, that could have gone a lot worse if I hadn't have done that. Fantastic suggestions, everyone. And if anyone has any more suggestions and wants to email them through to us or wants to talk a bit more, by all means, get in touch. It's been great to hear your thoughts. So I'm just going to wind up the presentation now, if that's okay. So we had a little think, as we promised, about the key barriers that face inclusion health populations. We thought about the impacts of the barriers, and we show those terrible health statistics linked to homelessness and the health outcomes that people experiencing homelessness face. And then we thought about how empathy can make a difference. And I think Ray has been giving us some brilliant insight into how empathy does make a difference in these real life scenarios. It's not theory, it actually makes a difference in real life. I'm just going to take this opportunity just to sort of promote that we have a few CPD events coming up, a few more learning events coming up. We've got a symposium coming up in later on in the year, which we're currently open for abstracts. If anyone's interested in submitting an abstract, if you go to our website and look for news and events, you'll find a list of everything that we're doing on there. We can follow the QR code on there. And then our next lunchtime learning event, which will be in a month's time, which will be with Dr. Felicity James, who's an associate professor in English literature and creative writing here at Leicester and part of the Empathic Centre herself. She's going to think about how creative approaches to empathic healthcare can make a difference. There'll be some sort of practical workshop activities within that, and it'll also look at communication skills as well. So that sounds really great. If you're not signed up for it already, I'd recommend it. And if you have got time before you leave, one feedback question is all we're asking for. If you've got time to fill that in, this is the first time we've done one of these sessions. You can add free text comments as well if you want to. It'd be really great to hear what you thought about today. I'd personally like to say thank you so much to Ray. Ray, it's always a pleasure to do any sort of teaching with you. You are brilliant at this, and your experience and what you bring to it is absolutely fantastic. So thank you very much, Ray, for joining us. And thank you, everyone else, for joining the webinar today. I hope you've enjoyed it, and I hope to see you at one in the future.
Thanks, Andy. Andy, can I just say that I work with peer leads who look after our peer volunteers. We've got quite a few peers working with us who have lived experience, and if anyone would want to either come out or just meet them, as it's been said, in a coffee shop, or not coffee shop, but somewhere that's comfortable, that they're welcome to come. Our peers they're all outgoing, and so they'll be happy to meet anyone.
Thanks, Ray. What a great offer. How would people access that if they wanted to do that?
I suppose email me or you, if you're not got my email address up there, and then I can coordinate a mutual place. We work at Dear Albert in Leicester quite a lot as well, so they've got plenty of rooms there. There's coffee there. There's safe space. So alternatively, as you know, we're open to people coming out and shadowing on occasions.
Thank you. That's great. Okay. Thanks, Ray. Thanks
Thanks
everyone.
very much. Thanks, everyone.
Thank you.